So let's get started. Welcome. This was a planned lecture. We planned this several months ago as part of EPID 835. I'm usually not available to speak during the usual time of EPID 835 in Wednesdays, so we'd always arranged for it to be this Monday afternoon. And it just seemed very opportune that we're talking about a framework for public health emergency preparedness. And in GEC, some of the student reps indicated that more MPH students would like to hear about emergency response and preparedness, and we're looking for opportunities to learn. And absolutely, this is an opportunity, so we're opening up this lecture. So welcome, and also thank you to the student reps for mentioning it in GEC. We were hoping actually to try and expedite and maybe get it to you last week, but like everyone, we've all been in some transitions, and our thoughts are with you over these transitions. But I'm hoping that you might find that this lecture can help you to frame a little bit what is going on. So
you may have to click on the slide now. Oh, with your mouse, sorry. And then,
great. So today I'm going to try and address and answer 4 questions. What is a public health emergency? What are the legal responsibilities at the local level around emergency planning and preparedness? How does a local health agency organize a response? And how does the public health system prepare for a pandemic? I'm speaking through my experience as an associate medical officer of health, where I played a role in planning the pandemic response for 2009 H1N1. So some of it is based on practical experience. Today, we actually won't be addressing specific situational questions. I'm sure there are a lot, and we're aware of it, particularly with your concerns around the uncertainty of the practicum. We're very sensitive to that. Please be assured we're working very hard. I was just speaking with Paula before I came to this lecture. So do stay tuned, and Paula is reaching out on your behalf and trying to provide as much clarity as possible, as is the department in communicating out on this. But this forum, it will not be a forum for addressing those specific concerns. Moreover, it will not be a forum to update you very specifically on the current pandemic and scenario, mostly because I'm not the voice of currency on that. When we have emergencies, it's very important to go to the current credible sources. I've put some links on this slide. At the local level, go to your health unit. I like to go to the WHO because they've got regular bulletins and updates. But today we will not be answering specific questions about the current scenario on the pandemic and its implications, nor on your current situation in the department as a student. We're going to focus on the learning objectives of the lecture. What is a public health emergency? Well, if you look at these photographs, some of them might resonate with you. And the big lesson here is that they're happening all the time. We have ongoing issues that are emergent and urgent public health emergencies. The ballerinas in the top, that could very well be the H1N1 pandemic. It could well be SARS. The train derailment, the dead crow. We certainly went through a lot of emergency responsiveness when West Nile virus came out initially as an emerging disease, as well ice storms. So there are definitely lots of emergencies that have public health implications. However, there is a legal definition of an emergency because there is a legal framework around emergency planning and response. An emergency is defined as a situation or an impending situation that constitutes a danger of major proportions that could result in serious harm. I'm going to focus on the impending for a moment. This is pretty much always the case with emergencies, that they're moving forward and there are uncertainties. They are impending. And we're experiencing that with this current pandemic, as we are all very much aware. When there is uncertainty around risk, as a public health professional, you will start to hear dialogue around the precautionary principle. Now, were you in class? I'd ask you to raise hands to how many of you have heard of the precautionary principle. It comes out often when there's a large-scale emergency and there is risk, but it isn't about the magnitude of the risk. That's not when we talk about precautionary principle. We talk about the precautionary principle when there is uncertainty about the risk, when we don't know what the risk is. The precautionary principle, according to the Canadian Environmental Law Association, it denotes a duty, a legal duty to prevent harm when it's within our power to do so, even when all the evidence is not in. So when we're uncertain about the risk, excuse me for a minute.
Observation suite. All clear, code 99, heritage 0, observation suite. All clear, code 99, heritage 0, observation suite.
Thank you. Sorry for the interruption. In the hospital, sometimes a code 99 is when someone needs help, and we have a team that responds. And once it's been addressed, there's an all clear, and you just heard an all clear in the hospital. So sorry for the interruption. Getting back to the precautionary principle, there is a legal responsibility, a duty to prevent harm when all the evidence to do so is not in. So let's take a look at this train derailment. The question is, if you respond to this, what is the level of risk here? What is the level of risk? And we're uncertain. What makes it uncertain? Well, we don't know if some of the carriages contain things that have been spilled. If we look to the right, we don't know if anything's been leaked into the water. We don't know at this time whether there's a draw in from that water and people drink that water. And we actually don't know what's going on the left. You know, is there a residence there or not? So there's a lot of uncertainty. When there is uncertainty, that's when it's very appropriate to introduce a precautionary principle and take precautions to prevent harm. So in this scenario, if a medical officer of health was called to the situation, it would be well within their duty, based on the uncertainty, to initially say, don't drink the water, and initially let's evacuate until we have a better idea of what's in the carriages. And this will have costs to individuals. People have to move maybe for a little bit, businesses will be stopped. And the medical officer is protected under the precautionary principle for asking people to do that under duty to prevent harm. That's when we're uncertain, and that's what the precautionary principle is. When the risk becomes more certain, then we need less precaution. So we relinquish precaution when the risk is understood. We bring in more precaution when the risk is uncertain. That's the precautionary principle. The two variables in the two sentences in front of you are level of precaution and level of certainty. What is the same in both of these scenarios is the risk. So the precautionary principle, we apply it when there is uncertainty of risk. Okay, so let's take another scenario. This is a fire in a subsidized housing estate. And I'm using this example because as an AMOH, it was something that I was involved with. So if we're at this scenario and we take a look at it. In the seminar situation, I would ask you to go into small groups and answer these questions. So I'll talk about it. So looking at that, is it a public health emergency? And if so, what makes it a public health emergency? What if I told you that behind the housing estate is a petroleum factory with some potential? So what makes it a public health emergency? It's the proportion. It's a proportion of danger to impact populations. That's the next question. So who is impacted in this scenario? And what are the immediate impacts? Well, this is a fire in a housing estate, so of course the residents are impacted. And if we think through, well, the first responders are responding, and maybe the landlord is impacted. They need to be saved, and then they need to be evacuated overnight and maybe for longer. So what are the potential longer term impacts? Well, I think we know of some scenarios where there have been fires in extended for large housing estates, and people are homeless for a long period. And think of the implications around that for getting to their work and separation of family. So there are a lot of longer term impacts. And then the question is, well, how could this have been prevented? We have heard some horrible stories where there haven't been the building standards needed to prevent fire. What about smoking in the home? How could these things have been prevented? And then the question, who is responsible for this and who should pay? And these are pretty standard questions that evolve with different kinds of emergency scenarios. So the take-home point here is that there are phases to emergencies, emergency planning and preparedness. Most of us, when we think of emergencies, we think of response. We think of the first responders, it's what we see the most. But that's only a quarter of the planning and response. There's the extended recovery. There's the mitigation, what could be done in future, lessons learned to prevent this. And then how can we prepare for that future? What is the training? So all of this are the phases in emergency planning and preparedness. And if you are responsible for emergency planning and preparedness, you have a duty to think through these 4 stages and to continue that circle. It's iterative and it's ongoing. I'll just do a check-in now. Is everyone hearing me okay? Is the pace okay? I'm not sure how to do that, but could you just type in and make sure that everyone's following okay? Okay, thank you. So we've talked a little bit about what a public health emergency is. And we said that it's a planning process and there are 4 phases. So the next question is, who is responsible for that planning? What are the legal responsibilities at the local level? At the local level, the municipality has the primary responsibility. The Emergency Management and Civil Protection Act requires every municipality to identify hazards and risks to public safety that could give rise to emergencies, and also identify facilities and infrastructure that are at risk. And I use the word municipality broadly because it could be a town, it could be a community, but it's at the local level. The local government has responsibility to identify local hazards and risks, and also to identify facilities and infrastructures that are at risk. So note to public health, as soon as you hear the word hazard, you're probably involving the medical officer of health. Under the Health Protection and Promotion Act, the medical officer has the duty and the authority to investigate and protect residents from hazards. Under this act, hazard is usually an environmental hazard or a chemical exposure. But under this act, the medical officer also has the duty to control communicable diseases. Those are the 2 big things with the Health Protection and Promotion Act. Environmental hazards, control communicable diseases. This legislation gives the medical officer quite extensive power to do what needs to be done to protect the residents within his jurisdiction or her jurisdiction, within the health unit, which is a geographical health unit. So, for example, if we looked at the emergency response plan of Simcoe District Health Unit, which is just an example, Their plan in the first chapter, it starts with what's called the HIRA, the Hazard Identification and Risk Assessment List. So the health unit has undertaken a HIRA to identify what are the likely hazards that are going to happen locally. And this is their list. Infectious disease, foodborne outbreaks, vector-borne diseases, so these are things like West Nile virus and rabies. Environmental hazards, ice storms, tornadoes, water-related hazards, low pressure, so not everyone's getting the drinking water they need, contaminated water, flooding, spills, like train derailments, critical infrastructure failures, power outages. So all of these have potential public health impact, and the Simcoe District Health Unit has identified that they need to anticipate response to these. Now, it makes total sense to do a HIRA because we can't plan for everything under the sun. We have to plan for what is likely, and this is what the HIRA helps do. However, the municipality also has to undertake a HIRA, and usually many of the municipal emergencies have public health implications, and usually the municipality and the local medical officer of health are working together on this. They're sharing their plans. The municipality, in addition to being responsible for identifying hazards and risks, and they're responsible for planning a response to that. Every municipality shall formulate an emergency plan, the 4 phases of that plan. In the response phase, they must continue provision of necessary services, as well as figure out who will respond to the emergency and how they will do that. So the big take home here is that when we're in the response phase of emergency, there are 2 duties going on. There's responding to the emergency, and then there's maintaining critical business operations. Now, depending on what organization you are with, that organization will balance more to one or to the other, either responding to the emergency or maintaining critical business operations. So look at the public health system. Look at all the different organizations that are involved. Question to MPH students, can you identify with some of those organizations? Are some of these who you are hoping or had hoped to have practicums with? So all of these organizations are right now trying to maintain critical business operations as well as trying to take their part in responding to what's going on. The challenge in public health is that it's our duty anyway to protect health. And this is a challenge sometimes. It's a challenge at the local level. Because the question is, when does usual business become an emergency? I've encountered this as an AMOH several times. So are we looking at 1 or 2 cases of E. coli in the community? Or is this a potential outbreak that's wide-reaching? And where are we in that understanding? When does usual business become an emergency? So we've seen 1 or 2 acute respiratory illnesses. Is that just a little bit more of a influenza or something else going on, or is something emerging? Very challenging. From a response phase, it's very important to make that declaration of when it's an emergency or not. Usually it's based on the scope of the scenario, because if it's a large scenario that needs a proportion of staff to respond, then it does mean that that organization, wherever you are in the public health system, has to suspend services, some services to redeploy staff, and that resources have to be expended. So, declaration is a legal act. To Declaring it gives who declares it, and often at the municipal level, it could be the head of council or the mayor. It enables and empowers the municipality, the mayor, to take action, including making orders that he or she considers necessary and are not contrary to law to implement the emergency plan. So declaration of an emergency gives the declarer, usually the mayor, powers to make orders, to take action, and also to implement the plan. Not contrary to law. So what does that mean? Well, let's just use maybe a scenario where there's a big train derailment. And again, the medical officer is working with the mayor, and it is an emergency, but it turns out to be a little bit bigger than we thought, that in fact a fair bit of the municipality has to be evacuated for a while. So what it means maybe at the health unit level is that we need more public health inspectors to go out and do an environmental assessment and help with the logistics. So we have to suspend some of our day-to-day services. For example, we have to suspend inspection of personal support settings. Sorry, I'm forgetting what it's called. Where the settings where, for example, we inspect on hygiene around tattoos and that sort of thing. So it means that we can't safeguard the standard in some of these settings because our public health inspectors are deployed. The reason that it's illegal is because there's now some protection. If in fact there's some degree of lapse in service, it's because we had to declare emergency and redeploy staff. So it's for these sorts of reasons that we have to declare an emergency, to suspend services, to mobilize resources, to extend powers and accountability, to release funds, and also to order and ask people to act or do things differently. And there is a chain of command in this, and you're starting to see this and hearing it occasionally in this current pandemic. Both the government and the medical officers of health have legislative capacity, and they tend to work together. At the local level, it's the mayor and the medical officer of health, but then you can go up to the chain, and you might need to if it involves more than one jurisdiction. So at the provincial level, it's the ministry, the ministers of health, and the chief medical officer of health. You'll see Dr. David Williams on the right. Going further up at the federal level, that's Dr. Tam, and yes, the Prime Minister. So there is a chain of command in terms of responding to an emergency. There are checks and balances, and that's because we live in a democratic state and there are pillars of democracy. The biggest one, when there's a declaration of emergency, and you saw that caveat in the definition, they have to abide by the law. So they cannot really break the law, and we rely on our judiciary to assist with that. And I am using the example of, I believe Trump tried to call an emergency to release emergency funds to build a wall, and I believe the judiciary disallowed that as a check and balance. However, I'm not sure if that was the end of that story, but that is one example of where that works. Not only do we have law to guide and protect, don't forget public health professionals, we also have our principles. We need principles to guide our interventions, because in these sorts of scenarios, our interventions restrict civil liberties. So you're looking at the picture of Dr. Ross Upshur. He's a colleague, and he was director of the Center of Bioethics in Toronto, and he has written on the ethics to guide public health intervention. He proposed a framework of 4. I'm just checking my time here. I think we're good. He's argued that public health principles should be guided under the harm principle, which declares that society has a right to intervene to restrict the liberty of individuals if, when we're doing that, we are preventing harm to others. So society has a right to intervene to restrict the liberty of individuals when that action prevents harm to others. You might apply some of that to some of the social distancing or enforcement of the social distancing happening in this current pandemic. Ethically, society presumably has the right for the greater good. However, when we invoke that principle, like everything, we need checks and balances. Dr. Upshur argued that if we are restricting civil liberties, and if there's damage to that for the greater good, then society has to reciprocate and support those who have made sacrifices for the greater good. And we're seeing that in this current scenario a little bit with funding to support those people who have been unemployed because they have to stay at home and these sorts of things. This is the duty of society to reciprocate and support. Reciprocal principle. He also suggests that we have to use the least restrictive means to protect. So we can't come in full guns. We have to use a stepwise approach to restrict civil liberties. We're seeing that in this scenario by advising on social distancing rather than legally punishing it, although some countries are needing to go up that ladder. But much of public health is based on education awareness and trying to use that to guide behavior, to use the least restrictive means. The principle of transparency is explaining why we are doing it, and it also brings an equity lens to it, that everyone is being treated and has to do similar. So that's an example of how ethical framework can help to guide public health action in a public health emergency. Okay, so far we've discussed what is a public health emergency, and it's of a major proportion, legal definition, responsibility to plan. We've talked about the responsibility to plan at the municipal level. Let's move a little bit more into a response phase though. So question number 3, how does a local health unit or agency organize a response to an emergency? How do you organize? When you consider that picture that we started with, the 4 different scenarios, they seem so very different. A possible SARS or a train derailment or an ice storm. So how do you organize a response that's flexible enough to deal with different emergencies? So we'll talk about that. We'll talk about that by looking at an example. Again, this is the Simcoe Muskoka District Health Unit. For those of you registered in the class, I know that you were given this resource ahead of time, and we can make it available to those interested afterwards. It's really just an example of an emergency plan for a health unit. There's no reason why I picked Simcoe Muskoka over any other health unit. If we look at that plan, there are 3 main sections to it. The first is how to declare an emergency and what's involved in it. Remember, this is a plan. It's sitting in the health unit. There are copies of it everywhere. Emergencies can happen really quickly. The first question is, what do we do? The next question is, where's the plan? And then the next question is this an emergency? And that's what the first section of the plan should address. The second section is, yes, it's an emergency, so how do we respond? The third is, well, we've responded, how did we do and what have we learned? The fourth and fifth is, what's resources in the plan can help us respond more efficiently and more effectively? What external resources and what internal resources? So let's go through the sections a little bit. We've already talked about declaration. What is an emergency? What is the HIRA, the hazards that are likely to happen in this? Who declares in legislation? The one thing that we didn't talk about is how do we recognize it initially and who recognizes it? And again, this is this threshold of, is this business as usual or is something more going on here? Remember, health units have folks on call 24/7. So it would be the person on call that would be called to whatever the evolving situation is. And so the first part of the plan has to direct that individual on call about what to do if it's after hours and we're looking at a possible emergency. So that's what the first section of the plan is looking at. The second section moves us into the response. And the first is, if this is an emergency, we need help. The health unit, the agency needs help from their staff initially. So staff need to be notified. So your plan needs to include how to call out folks. And then the next step is how to organize it and organize this response. You've probably heard in the news and maybe in some of the communications, EOC. EOC. It is the hub of the response organization in a facility when they go into emergency mode. The Emergency Operations Center. The center within the facility or organization where emergency operations are undergoing, the EOC. Within the EOC, roles are organized under a system called the Incident Management System, which we'll talk about. So I think this is probably everyone's imagining of an EOC. It's how it's depicted in films. Probably what you're looking at here, I think, is a training exercise, because the EOC is not usually this cluttered and clustered. People are wearing different jackets, different colors. In this training exercise, these jackets and colors, as in a response, likely denote what role they are playing in the emergency according to the incident management structure. So this is the incident management structure or system. If we take a look at the chart here, there are 8 roles: command, liaison, safety, communications, operations, planning, logistics, finance, and admin. They have roles. Command, as you would expect, has the ultimate authority to make decisions in the emergency operations and response. And that authority is often a legal authority. Liaison, they have to reach out and coordinate with the partners who are also involved in this emergency response. Health and safety, it's their duty to identify the health and safety issues primarily of the responders and staff responding. Sometimes health and safety of the residents, but usually that is more considered operations than health and safety. Health and safety is usually around staff concerns. Communications. Communications within the organization, communications outside the organization. Operations, so these are the folks that are responsible for coordinating the actual frontline response. Logistics, these are the folks that are responsible for supporting the operations with whatever they need, people and supplies. Planning, and this will resonate with the epidemiologists in the crowd. Planning, what data do we need to understand the situation, to monitor the situation, to anticipate the situation? Planning. Business, what is this costing us and how are we keeping track of it? Do we need to find more funds? Where do we get them from? The IMS is a fundamental structure for understanding and organizing an emergency response. This is a link that you can use to go to Emergency Management Ontario. The provincial board on emergency management, and they have training. So if you're interested in getting more training on this, they have training options. Okay. So what I'm going to do now is take you through an example of a response phase using the incident management structure, just to imagine through a little bit more what some of these roles are. The example that I'm going to use is the example from our last pandemic in 2009, H1N1, when we had to rapidly mass immunize a large proportion of the population to try and get herd immunity. Some might quibble that 40% is not herd immunity, but it's based on the assumption that some folks have already been infected and have immunity. This was a target. It was an arbitrary target that I'm using for illustration. But the goal is to deliver 48,000 immunizations in a short period of time. So the command, and in this case the medical officer of health, has the authority and the accountability for ensuring that this happens, and for making decisions and enforcing orders, sometimes to ensure that this happens. This is happening in our communities now, not at the immunization stage, but in the primary assessment stage. For those jurisdictions that primary assessment centers are being set up to direct people who suspect they might have COVID-19 or infected, they're being directed to a primary assessment center. So the organization and deliberations would be fairly similar to a mass immunization center. Operations, they have the responsibility to figure out how are they going to do this? How is it going to work? How are people going to be streaming? Who are we targeting? Do we have to prioritize people? What is their weighting? What do they need to support their weighting? It's the, how do we do this? What staff are needed? These sorts of things. Tactical operations. Logistics are right by the operations. They support operations with what they need. The biggest thing that they usually need are people, human resources. And if it's a health unit trying to respond, which is happening, people are being redeployed from their usual jobs to respond, to operate primary assessment centers, to operate mass immunization clinics if you get to that. So folks are not doing what they usually do, and they're being redeployed. Someone needs to organize all of that. Someone needs to do the staffing, the scheduling, the skills assessment. There needs to be what are called job action sheets for new roles, which I'll talk about a little bit. There's a huge amount of logistical planning to do this, especially if there's more than one partner involved. They need infrastructure and technology support, so computers, communication, supplies and materials. For example, do the arenas have enough toilets? Is there enough toilet paper? Very important. One thing that we didn't plan for in our mass immunization was women who were breastfeeding and a space for them to breastfeed, these sorts of things. Communication network, phones. So all of this needs to be set in place by logistics to get things up and running. So folks are being asked sometimes to do not what they signed up to do, but to do something else. You will find, usually when you're hired into a public health agency or as part of the public health system, you will find somewhere in the job description a statement saying that you will be asked and have a duty to respond to emergencies as directed. So there is a duty to respond and to a willingness to do as you're directed when there's an emergency. But sometimes you're asked to do things that you haven't been trained to do. I'll use the example of malign management when there's a panicked crowd trying to get access to a vaccine or having very long waits. Initially, sometimes people were redeployed who maybe were not trained to do that sort of thing, and found that they didn't have the skills or we didn't anticipate what to do if someone, for example, in the line becomes ill from the wait, or if there's anger and agitation and situations need to be de-escalated. So a lesson learned from us when we did it is that we actually had to use public health inspectors in this role rather than administrative staff and that sort of thing. Learning that, you now have a job action sheet and you'll know that for the next time. Okay. Communications. So again, we're just working down the IMS structure. Extremely important. It's usually the most challenging aspect of an emergency response. Internal communications, very important. External communications, and they can be the same and also quite different, with a reminder that it's a loop and that there need to be set up channels not only to send out but also to receive in. It can be a very challenging aspect, particularly in the early stages of reorganization. Occupational health and safety. Any sort of emergency transition redeployment, yes, it takes its toll through the transition. It can have health and safety implications as well as the frontline response. Absolutely, this is a consideration that needs to come through the incident management structure, and someone needs to have dedicated responsibility for it. Planning. I'll give you an example of planning in the mass immunization. For one, we needed to count people and try and get their demographic profile to understand who was coming to get vaccinated and who wasn't. We certainly needed to monitor adverse events to vaccines and figure out a way to do that. Interestingly, it was through the epidemiologists when we were doing mass immunization that we realized that supply and administration of vaccines weren't adding up. We were expecting to administer more than we actually did. And we were worried about vaccine wastage, and it was only the counting numbers that looked at that, and that's when we realized that the nurses were having difficulty drawing the last dose out of the vial because of the way the vials were constructed. And so with every vial that was, I think, supposed to provide vaccine for 8 people, we lost 1 dose. It's that sort of thing that we don't know unless we ask and we count and we figure it out. All of this costs money. Because it's declared an emergency, there will be provisions to compensate for it, but it's got to be accounted for and someone's got to be in charge of that. And it's not a single effort in a health system. It's a coordinated effort. So we need to make sure that all members of the system, as much as possible, are coordinated and not overlapping and doing the same thing. The liaison role can be a very big role depending on the scenario. For example, in this mass immunization, we did ask primary care and community health centers to take a role in administering vaccines on a large basis. So our liaison in the health unit needed to communicate with liaison in the community health centers and primary care to see how they were managing and if there were emerging issues happening in those settings that we didn't know about. And this is where the IMS structure is especially helpful. If every responding organization uses the IMS structure, then roles are clear and communication clarifies. Because command talks to command, liaison talks to liaison, communications to communication. This is what helps rapidly organize our response. Because in emergency, things change very rapidly, especially at the beginning. Believe it or not, things do become routinized at some point when risks become more clear and that sort of thing. But early on, when the situation is changing, those that with the lead roles under the IMS structure or their delegate need to meet very regularly in what are called business cycle meetings to update each other on how things are going. That's called the EOC business cycle meeting. An example of an agenda would be hearing from everyone in terms of what are the updates from your aspect, what are the issues that we need to talk about, what are the options that we can take to act on it, what decisions are we making, what actions will we take. Based on those actions, go back to your roles and incorporate them. So if you're communication, you need to communicate out those actions to the staff, to external links. If you're occupational health and safety, you need to see if there are any new health and safety implications for those actions. If you're liaison, you need to communicate with your partners about what decisions have been made. So this is where the IMS structure can be very helpful. What also can be helpful is the quality of your plan and how prepared you are. In Simcoe Muskoka, the plan, that's chapter 4 and chapter 5. Chapter 4 is resources for external partnering and concerns, and chapter 5 is resources for internal. So in terms of external, who are your community partners? What are your relationships with them? Are you up to date with contacts? Can you anticipate communications that you're going to have to draft already, and can you have templates ready to go? It's very common in some scenarios to do a boil water advisory. What can you do ahead of time to be more efficient? So resources for external, chapter 4. Chapter 5, resources for internal. So you've heard that people need to be redeployed. Sometimes in a pandemic, similar scenarios come up. Primary assessment centers, vaccinations. So the good plan already has job action sheets. We know that there are issues now with line management, so maybe there's a job action sheet for that. So these need to be kept up to date, as does staff fan out, so that we can quickly reach and contact people. Is everyone's training up to date? Is training up to date in emergency planning and response? So rest assured, if you are hired in an organization that has a role in responding to a public health emergency, that organization has some duty to train its staff. So you will undergo training as a member of the organization. Myself, I received most of my training through employment on how to respond to emergencies and what's required. And that does usually include annual recent simulated PAN partner scenarios and emergency response. So that picture that you saw of the EOC, that's probably a training exercise of response. The third section of the Simcoe Muskoka plan is after the response, the evaluation stage, although it's not that discrete, because there should be some duty to evaluate throughout the response, because that's really the only way that you know if you're on track a little bit, okay? But there needs to be a process for ensuring that there is evaluation going on and that it is being brought to people's attention, and that changes are being made on its basis, yes, during, although that's also planning, but absolutely after. And based on lessons learned, how do we improve our plan? How do we review it and test it? Okay, so we've gone through 3/4 of what we wanted to talk about. Although I agree this isn't talking, this is me talking to you. I apologize for that. But what is an emergency? We've covered that. What are the legal responsibilities at the local level? How does a local health unit organize? And because there's an iterative process, because there are lessons learned, we can incorporate some of that in this question now. How does the public health system prepare and respond for a pandemic? The good news about pandemics is that they occur, they have a periodicity to it. So we know that there are some predictable phases in pandemic. What you see in front of you is the classic phase. Now, I'm not going to talk directly on the current pandemic because it is changing so quickly that I would likely provide misinformation. But we are somewhere probably between phase 4. In fact, I think we're at phase 4. Some evidence of sustained human-to-human transmission, and we're trying to reduce that transmission to slow down phase 5. We have lots of lessons learned from previous pandemics, although most of them are based on influenza. There are some similarities, though, to this pandemic. The good news is that the last pandemic was in 2009, and so everyone in this webinar has survived a pandemic already, and many of us have had the experience of organizing and responding through it. So what is a pandemic? It's an epidemic that occurs worldwide, affecting a large number of people with sustained transmission. What it doesn't have in many of the definitions is the caveat of severe illness or not. And it's true that pandemic, literally, it really just is, you know, a large geographical spread with sustained transmission. So you can get pandemics of different severities. Hence, the 2009 H1N1 was less severe than anticipated. So what do we look for a pandemic, and what can escalate the transmission? Again, I'm not going to give you up-to-date information on COVID. This was borrowed from a lecture I attended from Gerald Evans, who's the infectious disease lead on this in Kingston, from March 10th. And what makes this COVID virus a pandemic is mostly the top one, the velocity of transmission, that it transmits very quickly. And he gave as an example that this was based on March 10th data, that with COVID-19, once it was detected, it was estimated to take about 48 days to infect 1,000 people. And he used SARS, which was a similar virus, I think in 2003. In 2003, it took the SARS virus 130 days to infect 1,000 people. So this virus just travels more quickly. On March 10th, the proportion of infected people that had severe disease was 13%. The case fatality was 1 in 50. Those who were susceptible were elderly and had cardiovascular disease. At that time, the mean incubation period was 5 days. At that time, the reproductive rate, which is the average number of secondary cases that occur when an infected person contacts a group of susceptible, is 2 to 3. And they were also trying to figure out how to shed. So I'm just using these, they're not up to date, but these are the attributes of a pathogen that we look at, and it's these attributes that tend to suggest pandemic potential. And my understanding of COVID-19 is the velocity of transmission, how quickly it spreads, is what escalated it to a pandemic potential. To put things in perspective a little bit, because Dr. Evans did this and I found it helpful. So the average number of secondary cases from a susceptible, so it was estimated for, on March 10th, it was estimated for this virus that 2 to 3 people in a group of susceptibles would be infected, whereas in measles, the R value is 13 to 14. So measles is, you're much more likely to be infected if you're exposed to measles than if you are, for example, to COVID-19, based on March 10th data. So the phases of a pandemic, and this is in most plans. Phase 1 is when the virus is first being identified. Often it's come from an animal, starting to affect a few people, and the question is how easily does it transmit to others? That's how you characterize the early phases. Phase 4 is when there's sustained human-to-human transmission, and phase 5 is when it's widespread in the community. Under pandemic planning and direction, when we're in phase 4, that's when we need to escalate rapid containment of transmission. And I believe, although I'm not speaking on behalf of it, but I believe this is what's happening right now, that we're working very hard to rapidly contain it to reduce widespread human infection. We're in phase 4. And I think you're all aware that the aim is to reduce the caseload so that we can reduce the burden on our healthcare system. That's one of the primary aims. Now, because we've dealt with pandemics before, there are plans. So this link, if you go on it, it will introduce you to the Public Health Agency of Canada's Pandemic Preparedness Plan. This plan has at least 7 components to it. There's a plan for surveillance and lab services. So this has to do with testing to confirm, and it has to do with surveying to know where the activity is and what is its pattern of spread. Now, sometimes not every case, when there's known level of activity and you are hearing this, not every case needs to be tested because of the likelihood that, yes, it is a positive case. And that's because sometimes the tests need to be preserved so that we can outreach and measure surveillance, test with surveillance, so that we can know where it's going and get a population health sense of its spread. And you will be hearing some of our leaders talking about this now. So surveillance and lab services, always a part of a pandemic. Second part, public health measures. So this is where public health moves into protect, and it's mostly around social distancing and what can an individual do, the behavioral changes around hygiene, the social distancing that you're hearing in the community, border travel, all of this is in the plan. But I'm going to come back to that a little bit. Number 3, vaccines and antivirals. So vaccines, that's usually development phase to see if we can find something that can give enough of an antibody that's effective to prevent people if they're not infected already. Antivirals, that's a medication to treat those who are infected. Sometimes they're also prophylactic to prevent infection. Always a part of the plan in a pandemic. However, with a new virus, sometimes there needs to be a new vaccine, and sometimes old antivirals are not effective. Infection prevention and control, a dedicated part of a pandemic plan. What can we do to stop transmission? The most important part there is figuring out how does it transmit in the first place. We're hearing in this one, it's respiratory droplet. We know how respiratory droplet is transmitted. We know that you need to be cleaning surfaces, that you need to be social distancing, that you need to cover your coughs, these sorts of things. So infection prevention and control, we know what needs to be done to clean surfaces. Healthcare services, how do they reorganize? And again, we're borrowing on lessons learned from influenza. What do we tell individuals to try and prevent from getting illness? And if they are feeling illness, you know, the isolation, the reaching out for help through the telephone triage, the being directed to the primary assessment center, which is away from the healthcare facility because we're trying to reduce any potential contamination and load. But if necessary, go to a secondary and then sometimes a tertiary. So there's a pathway of care that needs to be planned, and that is underway. There also needs to be very special consideration for remote communities, which we're hearing about the susceptibility, particularly amongst our First Nations populations. That's part of the plan. Clinical care guidelines. So quickly to disseminate out to those who are close to the lines and responding, what to do, how to treat. Communication is huge machinery that needs to happen. The big thing is consistency, responsiveness, inflow, outflow, evaluation. Lots of planning that needs to happen there. And then research, particularly if there's new and emerging. What do we need to know? Who can help us know that? How can we understand it rapidly? And how can we explain it to those who need to be explained? All of that is part of the research. So if you look at the pandemic, PHAC pandemic plan, you'll see that there are all of these aspects of it. And then if you look at your local response, you will see that operations are occurring on these levels. Now, what I highlighted in red is number 2, public health measures. So this is what seems to be unique about the current scenario, is the extent to which we are relying on protective public health measures, in particular the social distancing. And I think this is also where some of the research needs to happen. This is just my perspective. So for an example, if we look at this article, it's a 2011 article in mathematics, and I'm sorry if you can't read it very well, but the final paragraph said that based on modeling of spread of influenza, because we do try and learn lessons from pandemic influenza, that final sentence, we find that over 50% of all influenza infections in the elderly are caused by direct contact with an infected child. And we determine that social distancing between grandparents and grandchildren is remarkably effective and is capable of reducing influenza attack rates in the elderly by up to 60%. So if we model based on pandemic and influenza, then there certainly is modeled evidence and justification for social distancing. And yes, we have to work with best available evidence. As we wait for experiential evidence, which is happening. But I think it also creates a response challenge, and I would suggest it might be a rapid response challenge, because it poses the question, how now does the public health system organize to support vulnerable populations throughout an extended isolation period? Because I think this is one of the new scenarios that we're dealing with. We do know that social isolation also can be an independent risk factor for poor health outcomes. So we're trading off risk factors, and I don't think anyone would argue that the risk of COVID exposure is a greater risk, but we do have to mitigate the risk, and we have the duty to reciprocate. And I think this is one of the issues that we need to look at right now. How does the system organize to support the vulnerable populations throughout extended isolation? I would even say that there's probably a health equity impact assessment component to it, because I think that the risks of isolating are unequally distributed. So this is where public health comes in. This is the skills that you're starting to learn. This is where we need a rapid review of the literature, because there is information out there on how we reduce social isolation among the socially isolated. For example, in the frail elderly, there are studies and research out there. And where are we in the cycle? Well, how do we adapt to this, to currently what we need to do? And how do we implement it and then evaluate it? How do we do it rapidly? This is where our circle, this is where the evidence to action circle comes in place, and also it helps us organize our thoughts around it. So where are we in this? I did go to the World Health Organization myself to look under research to see if these sorts of questions were being posed. I don't think they are yet. Not that I by any means am abreast of all the evidence right now. I am just going to the WHO to see what's there, but if you go to this website, you'll see that there is a dedicated research, and you'll see the kinds of research that is coming out. So far, a lot of it is understandably on understanding the virus and transmission, but we need to also rapidly understand how to implement the response as best as possible. And it is rapid right now, rapid transmission, rapid containment, phase 4, rapid review of the evidence, rapid response, rapid reorganization. So when you first were introduced to public health, it was defined as the art and science of presenting disease, prolonging life, and promoting health through the organized efforts of society. And I would suggest it's also through the reorganized efforts of society, which is what we are needing to do. So in summary, the emergencies and pandemics in public health, they're new and they're not new. The IMS offers, the incident management structure offers a consistent way of organizing as well as staying flexible, and a consistent way of communicating, understanding roles. We have periodicity to pandemic and pandemic plans, and currently these are being implemented. We do have lessons learned from previous pandemics, but there's always the need for new evidence to be synthesized and to inform action. And you can see that it can be our lifesaver.
So if you're ready for questions,
Okay.
people can unmute themselves.
Oh, and Julia, can they hear you?
I believe so. At least I
Okay.
can hear myself on the headphone.
So if there are questions, feel free to either unmute or to type them in.
Erica, I guess it's Harriet. I'll ask the first question. Thank you so much for that excellent presentation. Could you distinguish a little bit more from me, maybe the others already know, the sort of the differences in primary, secondary, and tertiary triage sort of in the healthcare services?
Well, traditionally, primary care is family physician and outpatient care, and tertiary is hospitalized care, and secondary could be considered hospitalized and tertiary with ICU support and that sort of thing.
Okay.
That's in the healthcare system. However, it's used slightly differently when we're talking about primary and secondary assessment centers. And you need to go to your local health unit to see how they're describing it. People who, in this scenario, are feeling that they might have disease are being advised to phone in, telephone triage, and then sort of based on that, they're being advised whether or not they need to go for an in-person assessment at a primary assessment center, and then they're further triaged on whether they need to go to secondary and tertiary, depending on their care needs.
Thank you.
Hi, Erica.
Hi there.
Sorry I logged in late. I just was coming back from another lecture. And so I don't know if you talked about this, but I'm curious to hear about any feedbacks you have on how the current pandemic has been dealt with in our country or professionally from, the initial press conference to now.
I'm sorry, who's talking?
Daria.
Daria? Now, how do I see that? Okay. Well, that's a pretty big question. And I have to say, I mean, I only have my perspective on it, but when we look at the plan and we look at the lessons learned, and having had the experience in H1N1, in my regard, I understand and agree with the actions that have been taking place, and I'm agree with the decisions and the pitch. But that's my perspective. To be honest, I've been quite proud of my colleagues. Yeah.
Okay, thank you.
Yeah.
Oh, Shannon Russell asks, I'm not sure if you said this already, but when comes to the declaration of an emergency, who does that come from? In the municipality, is it the mayor?
All right. So in terms of technology, when someone types in a question, do the rest of you get to see it, or does it only come to me?
We can see everything.
Great, great. Does it come from, who does it come from? I think it sort of depends on how the act is interpreted. One thing that I forgot to emphasize is that when there's an emergency, there's always a lawyer to consult. And I don't know the actual terminology in the act. Usually it's one or two folks, like I'm wondering if it's mayor and or delegate. So I don't know the specific question, and I haven't been involved at the municipal level, but I believe I think the terminology is head of council. I think that's a terminology. But there would always be a delegate in case the head of council is not available. One thing I can add, though, is that the medical officer of health has absolute authority if it's a health hazard or an infectious disease to do what needs to be done to control. So their primary aim is to protect the health, and they don't necessarily need the okay from the municipality to take action to protect health, but they will be working with the municipality if it's on that scale.
Thank you for the answer, Erica.
Yep. Every emergency that I've been involved with, or when we're not sure if it's an emergency or not, because that can be a very difficult threshold, there's always been the lawyer at the table interpreting the act for us. Are there any other questions? No, we were scheduled to go to 3 o'clock, is that right? Yeah.
Erica, I guess I have one question. I was typing it. I'll just say it. It's Harriet again. You talked a bit about the precautionary principle earlier on, and sort of the uncertainty of risk is sort of puts us in a place right now where we're following the precautionary principle. Based on your prior experience, sort of what type of evidence or certainty do you think we'd be looking for to sort of relinquish this precautionary principle in this current climate with COVID-19? I know you said you don't want to talk about it too much, so you could take a pass on that question if you want.
Well, the variable is the level of uncertainty. And I think there still is a significant level of uncertainty. However, I think there were lessons learned from some countries where the extent of precautions were not taken. And that becomes evidence. That's experiential evidence. So we can relinquish the principle a little bit, but still continue with the social control measures that are needed, because there's evidence that they're needed because of the risk.
Right.
If
Yeah,
that makes sense.
Yeah, that makes total sense.
Yeah. Yeah. This is where, unfortunately, we're in the fortunate position of seeing how other countries, what's happening there, and that's evidence for us.
And so, as you point out, relinquishing the precautionary principle doesn't necessarily mean you relinquish the social control measures that have been put in place.
Absolutely not.
Right.
No, the only thing you're doing is you're more certain about your level of intervention.
That makes sense.
Yeah. Yeah.
Well, I guess if there are no more questions, this has been so informative. Thank you so much.